My name is Dr. Nupur Hajela. I am the Director of Center for Digital and Technological Innovation in Healthcare at Fresno State. Today, I'm wearing a hat of the Secretary for Academy of Leadership and Innovation. This is from APTA, and I'm really excited to have a very special guest, Dr. Harsha Deo. He is the Associate Dean in the College of Science at Cal Poly Pomona. Welcome, Dr. Deo.
Thank you so much for inviting me.
Well, you can tell us about yourself and your journey so that our viewers can know what have led you to where you are today.
My journey started as a trained physical therapist, working in the clinic, really learning through traditional physical therapy education with a lot of hands-on experience in with patients. And then my PhD was involved in more musculoskeletal and kind of the different physiological impacts on muscle physiology, different pathological impacts on muscle physiology. And as I kind of transition from an acute care therapist more towards an educator, um, the focus became how do we make sure that our students are not getting just kind of an exposure level training during their physical therapy education, but they get to practice more hands-on practice. But when you think about like acute care environment, it's very patient-oriented, safety-oriented, and it becomes very difficult to train students without kind of putting your patients at risk, and kind of giving an opportunity for students to really think critically, make those difficult clinical decisions while in situations where the patient's safety is extremely important. So that kind of really pushed me towards identifying more opportunities for teaching students using simulation. I was at Fresno State. We had a state-of-the-art simulation lab that gave a lot of opportunities to create simulation, both just for physical therapy students, but also interprofessional simulation with nursing students. Uh,
Mm-hmm.
they also had, in addition to kind of general high fidelity mannequins, we were also very fortunate to have a mechanical ventilator and all other kinds of instrumentation. We also got trained through the California Nursing Association has a training program for simulation. I was fortunate enough to get trained two certification levels they have.
Mm-hmm.
She really taught the pedagogical part of simulation. How do you create it, run it, the pre-briefing, the debriefing, but it also kind of made me understand some of the logistics that we need to be aware of when we are working with larger groups of students. And when
Mm-hmm.
I became kind of a physical therapy administrator, those logistic barriers became more and more apparent that, oh, you're trying to have larger cohorts, you want them all to be successful in acute care,
Mm-hmm.
which is in a lot of the programs have kind of students have that kind of a weakness when they're
Mm-hmm.
graduating and getting into the clinic. So everybody's trying to figure out how do we do it more effectively, but at the same time efficiently, because it's a lot of human labor that is required, a lot of instrumentation required, and space and all those logistics really make it hard for giving every student kind of practice level experience. Most of the time, we end up giving them exposure level experience.
Yeah.
So then kind of really pushed me more on what other technology that can be used. And that was my kind of first introduction to virtual reality. And kind of that triggered me towards this field. So
Yeah, no, I think that is a very, I would say, exciting way of how you kind of try to figure things out. And, as a clinician, as an educator, and now as an administrator, I think we always want to make sure that it's student centric. The students are at the core of it and how we can make them successful. So I want to let the viewers know that through this, Innovate Ed series, today we are trying to put a spotlight on a new technology that Harsha just talked about, which is virtual reality. And though we have heard about virtual reality, had read about virtual reality from many different lenses, because even virtual reality is used as an umbrella term. It could be in a way that you are watching a video, but now I think we are moving more and more towards immersive virtual reality because we understand what are some nuances that we were missing when we were just doing more of the one which was not immersive. So walk us through, as I was trying to read more about you, I realized that you were at the forefront of actually using virtual reality in an interprofessional setting. And I know that you did touch upon from a simulation aspect, but walk us through that, when you transitioned from, and not exactly transition, but how do you see virtual reality and IPE, which is interprofessional education, and simulation?
Yeah, I mean, at Western University, we have a long history of really getting engaged in interprofessional education. They have been pioneers of interprofessional education in various different fields. So every Wednesday we had this, the whole university basically shuts down because everybody's now, all the students and all faculty are involved in these problem-based small group sessions where we discuss different case-based, I mean, cases or problems. And then the student groups, which involves all different health professions, at least nine different health professions together, and they're kind of really solving these patient-based problems and learning all the IP skills through it. One of the major issue was kind of student engagement in these activities because a lot of the times it's still case-based, paper-based versus really something hands-on. And even if we were kind of able to achieve some of the IP competencies through that, it wasn't very strong student engagement in it. And a lot of the times the students wanted more something hands-on, something where it's more engaging, where it's patient-focused versus just paper-based. So we were trying to think about different ways we can do it. So we were able to schedule some of these IP sessions in our simulation centers, and we use both the high-fidelity mannequins, but also standardized patients.
Mhm.
Both of those were kind of really highly valued by students for engagement, for their ability to kind of communicate with each other, understand each other's roles, responsibilities, and really kind of turn those experiences into very strong kind of learning opportunities. At
Mhm.
the same time, when we have like 800 students going through these simulations
Wow.
on a weekly basis for kind of multiple IP, one IP, two IP, three courses, it
Mhm.
was logistically becoming extremely difficult, scheduling wise, space wise, but also very expensive. I mean, the standardized patients are
Mhm.
extremely expensive. The high fidelity mannequins are a large investment at the beginnings, but they also break after so much use.
Mhm.
So we were thinking what else can be done where we don't have to then restrict student experience to certain numbers based on our ability to deliver. And so we were looking into other avenues, and that really led us to kind of writing an intramural grant to look into the use of virtual reality. We kind of were slowly introducing virtual reality in our anatomy and physiology education because that really creates a very immersive environment for students to kind of use virtual reality headsets to really learn about anatomy and physiology and kind of get tested through that environment as well. And kind of that was very high student engagement thing we found. So we were thinking, can we now take it to the next step and really look into maybe doing this as an interprofessional experience? So the intramural grant funded for us working with our nursing students and our optometry students, and we were able to create a three-dimensional virtual reality scenarios, and we were able to kind of connect multiple of those scenarios to really take them through the life of a patient. So some of the aims were to basically check and see if this simulation is equally engaging compared to maybe just a regular computer-based simulation or a standardized simulation. Because compared to both of them, this was kind of on the cheaper side.
Mhm.
Uh, Other aim was really to see the simulation itself or the scenario itself was focused on building empathy for a patient who's homeless by going through this whole simulation as an interprofessional team. And we were able to show that through that specific research study that this was equally, if not better or more engaging than even the standardized patient or just computer based. But the empathy scores were significantly higher on the virtual reality simulation as well. So this was a great success. And then we kind of integrated virtual reality, that specific one we created in our general interprofessional education, which went beyond just the students from physical therapy and optometry and nursing. And now it's kind of becoming part of the regular IPE schedule, where one of the modules is based on virtual reality using the scenarios. And we are building kind of more scenarios to simulate all different kinds of clinical specific ideas, new things that are getting integrated in it.
No, I think, this is so valuable because uh, I personally use virtual reality. I treat patients with Parkinson's with virtual reality. And what I found interesting was, sometimes we have these, I would say, assumptions about what patients may like and what not. And, some of my patients were kind of 80 plus, and they just thoroughly
Mm.
enjoyed virtual reality, to my surprise, because I was thinking maybe technology, maybe they don't like,
Mm.
using the setup. But the moment they had it on and they were looking into those virtual environments and interacting with it, some of them, actually forgot about their pain. And that was like a win for me as a clinician, that if I can keep them engaged longer in a
Yeah.
therapy session, I
Yeah.
think I could, optimize that time frame. Because what we find is when they are not immersed, we have to give them rest breaks. They have to,
Mhm.
we have to give them time to kind of recover. And
Mhm.
sometimes that becomes monotonous, right? So I
Mhm.
think this is definitely breaking down those kind of, I would say, scenarios. But I want to kind of take another, I would say, angle to it, from the perspective of telehealth, and from the perspective of hybrid care models, because we understand that, obviously, COVID taught us that, we don't always have to be hands-on. We can do many things in a different model. What are you seeing? You are in an area which is obviously very highly populated. I'm sure there are also, maybe there are pockets which could be underserved also. So what is your take on virtual reality and telehealth or hybrid models?
Yeah, I mean, there are kind of access issues in some of the areas for patients, both Wi-Fi access, access to VR instrumentation, but all of that is improving at an exponential basis. The prices of VR headset used to be significantly high when we bought our first headset for our intramural grant, and now we see those numbers are kind of significantly going down.
Mm-hmm.
Uh, and the ease of use has been improving. So even for older patients or somebody who's new to technology, kind of all those barriers are kind of getting lesser and less. So this is kind of becoming more and more feasible for reaching out a much larger kind of group of patients who are not kind of readily available for work in the clinic. But
Mm-hmm.
this immersive experience can really provide a lot of different kinds of exercise that can be very precisely dosed for them, which is another really important part of the instrumented therapy, that you can kind of really dose it perfectly and you can collect a lot of data simultaneously to make it more kind of personally accurate for that patient. So
Mm-hmm.
those are kind of some other things that we are going to explore that that will be really helpful for really moving our profession forward. I mean, we see the use in neuro rehab. I mean, you are using it in your lab, the balance training, all kinds of places, even kind of pain specific rehabilitation has used a lot of immersive VR simulation. And
Mm-hmm.
a lot of the times it's because of the immersive nature and then the patient engagement. So
Mm-hmm.
it's very kind of easy to keep them engaged in it for a longer period, as you said, like much less breaks they require, much less fatigue. And if they
Mm-hmm.
can do all of this through telehealth plus kind of a consumer VR that they can have at their home, and right now MetaQuest is like $300. Uh,
Mm-hmm.
it can really bring a lot of supervised rehab to a lot of our rural patient communities, but also like low income patient communities who can't always come to clinic or have transportation and other issues.
Mm-hmm.
So this kind of new technology is really helpful, and maybe our students need to learn
Mm-hmm.
or get a chance both to use it to learn, but
Mm-hmm.
also use it to kind of use it as a rehab toolkit. part
Mhm.
of their toolkit for providing care as well.
No, this is very valuable. And I think I want to finally, talk to you because you are also an administrator. You not only oversee just rehab, I think in your current role, I think you are trying to shape how at the university levels, things in terms of whether it comes to allotment of funds, whether it comes to talking about collaborations. Where do you
Mhm.
think, not just VR, but emerging technologies, I would say digital technologies, so to speak, are playing a role from in your mind as an administrator? What do you think? How should other administrators think about digital technologies?
I mean, we always, as administrators, want not to start with technology, but start with a problem and then
Mhm.
what technological solutions you have. We also don't want to kind of scale it before we have enough evidence that this technology really works. So we are not just bringing in more and more technology without really scrutinizing if it's actually improving efficiency, is it effective or not. So those are the things kind of you have to think about. Whenever you're introducing any new technology, and a lot of the times it shouldn't be kind of a approach where the administration is pushing for it, but your faculty, your clinicians, those should be kind of co-creators of that solution using technology. So that's kind of have been has been my approach for any of the problems we see both on the education side or clinical side.
Mhm.
And then how do we not just kind of test the technology, but also look at what is the ease of use on your patient side, but also what is the uptake from your clinicians, right? So that they
Mhm.
can be, there is a significant buy-in from them in the use of the technology. It doesn't just become something that's kind of evidence-based and efficient, but nobody wants to use it because there's a very steep learning curve to it, right? Especially
Exactly.
with kind of the VR simulation or IPE.
Mhm.
A lot of things you need to learn in creating the IPE, and a lot of that requires you to collaborate outside of your physical therapy
Mhm.
units. And we were fortunate that we had a whole kind of technology incubator, and people from there were able to help us. But we also had external companies from Netherlands. Actually, they created the actual VR based IPE part for it. So we did all the recordings and scenario creation and the actual pedagogical part of it. They just help us with the technology. So you're gonna go beyond your traditional healthcare partners and now create those connections. And working at Cal Poly now, I work with computer scientists and people who are really involved in this. So it is
Mhm.
helping me kind of explore more simulation experiences. And we already are connected with veterinary medicine and all other kind of health professions to help them create VR-based simulations so they can really teach their students a lot of the things in a very safe environment, very student-focused environment, but
Mhm.
very immersive and very realistic, very high fidelity environment. So they're ready for their professional practice.
No, I think it is important from learning from you, about these aspects of technology because I think what I liked what you said is I think it should be from the problem and not the technology is still a tool to
Mhm.
solve certain problems. I think lastly, I want you to touch upon obviously, a physical therapy per se is a we always thought of very hands-on profession and it still will remain because that's why we know that patients come to physical therapists, but we also know that technology is kind of rapidly evolving. So what will
Mhm.
be your last final thoughts given that we are doing this for APTA ally and we want to make sure that the innovation remains the core of moving the profession forward? So what is your take on it?
I mean, we have virtual reality, we have augmented reality, we have robotics, we have AI, all these techno or wearables, all of these are kind of now evolving at a very rapid pace. So as a physical therapy profession, we need to be really on the forefront of it versus trying to catch up. A lot of these are getting like there are almost 750 different codes or programs are being approved for AI-based use, which means those are number of tools, number of instruments, number of softwares, technology that can be used. So we as a profession have to be kind of in the know of things and have to be at the table where we are kind of really driving the decision so that we can really advocate for our patients, for our students, as well as our profession. At the same time, this technology is not a replacement for a physical therapist. I mean, our patients still need the hands-on approach. They still need to see a real human being. So I think we have to also train our students for more humanism as well, in addition to when we are teaching them about all the technology use. um, but that's kind of what our education needs to evolve, our curriculum needs to evolve. We need to really look into what things we don't need to teach or things we need to teach differently so that we can create avenues for integrating this new thing in our curriculum without really expanding our curriculum too much further. But again, our VR, again, that will be augmenting the curriculum, that will be augmenting our practice, but really not replace the therapy and patient relationship. That has to be kind of at the center point, or the teacher and student hands-on training that will be still at the center. But this, hopefully, this will make education, clinical practice more effective, more efficient, and will have significant amount of data for really identifying things, what are working, what are not working, and really kind of take our profession forward at a much rapid pace. And I hope that is kind of the integration of technology will do to us. So
Yeah, no, thank you so much, Harsha. I think this was very valuable. I know that how busy you are, and still you found time to kind of do this for APTA Ally. So thank you so much for your time.
sure, thank you for inviting me. Thank you for asking these really nice questions, which made me think about my journey so far, but also the future that we are trying to co-create, all of us. So thank you for this opportunity.
Thank you so much.